Welcome to drppt.in Medical Update. Today, we're tackling a really critical topic for anyone who manages patients with cancer, tumor lysis syndrome. We're going to break down the key updates from a major New England Journal of Medicine review that honestly might just change the way you think about this oncologic emergency. So, let's just get right to it with a question for you. Is your clinical approach to tumor lysis syndrome really up to date? We all know the basics, right? But with cancer therapies evolving so fast, the whole game has changed. This update is all about making sure your approach is lined up with the absolute latest evidence. And here it is, the headline right up front. The classic villain that we've all been taught to fear in TLS-related kidney injury, well, it might not be the main culprit anymore. This is the big paradigm shift we're going to explore today. Okay, so let's start with the why. To really get this shift, we've got to look at how our understanding of the pathophysiology has evolved, and in doing so, it's revealed a brand new villain in the story. Just as a quick refresher, at its core, TLS is just this overwhelming release of intracellular stuff. When a massive number of cancer cells lyse, or break apart, they flood the system with potassium, phosphate, and nucleic acids, which then get turned into uric acid. It just completely overwhelms the body's ability to cope. And here is the plot twist. For decades, we thought the main bad guy was uric acid, these crystals just clogging up the renal tubules. But what we know now is that the evidence points to a new primary driver, hyperphosphatemia. That high phosphate leads to calcium phosphate depositing in the kidneys, causing direct tubular injury. So you might be asking, why the change? Well, it's actually a story of our own success. Rasburicase is just incredibly good at dropping uric acid levels fast. And by doing that, it's basically unmasked hyperphosphatemia as the dominant leftover threat to the kidneys when we're managing TLS today. So how does this new understanding actually translate into our day-to-day practice? Let's take a look at how we should be identifying patients at risk and making the diagnosis in this new landscape. You know, the classic high-risk patient, someone with Burkitt's lymphoma or ALL, that hasn't changed. They're still high risk. But the field is way less predictable now. We've got these highly effective targeted agents like venetoclax that can cause profound TLS in diseases we used to think of as lower risk, like CLL. And we're even seeing emerging reports with things like checkpoint inhibitors and CAR T-cell therapies. Now, for a formal diagnosis, we're still relying on the good old Cairo-Bishop criteria. To make a lab diagnosis of TLS, a patient needs to meet 2 or more of these specific thresholds or have a 25% change from their baseline, all within a single 24-hour period. But remember, lab values alone aren't enough to call it full-blown clinical TLS. You also need to see evidence of end organ damage, which is defined as at least one of these clinical criteria: acute kidney injury, a serious cardiac arrhythmia, or a seizure. Okay, so we figured out the risk and we know how to diagnose it. How do we actually apply all of this at the bedside? Let's walk through the modern management playbook. With TLS, prevention is absolutely everything. Before you even think about starting anti-cancer therapy in a patient you flagged as high risk, you have to do 3 things. Get your baseline labs, hold any drugs that could be tough on the kidneys, and, most importantly, start aggressive IV hydration and get your hypouricemic agent chosen and on board. And this brings us to a really key decision. Allopurinol is a classic, right? It stops the formation of new uric acid. But here's the catch. It does absolutely nothing about the uric acid that's already there. Rasburicase, on the other hand, it's like a molecular Pac-Man. It just gobbles up existing uric acid, enzymatically converting it to this super soluble compound called allantoin. And it does this in a matter of hours. So if you're going to use Rasburicase, you've got to know these details. First, a single weight-based dose is often all you need. You probably don't need that full 5-day course in many cases. Second, it is absolutely contraindicated in G6PD deficiency because of the risk of severe hemolysis. And third, please alert your lab. The blood sample has to be put on ice immediately. If it's not, the enzyme keeps working in the tube and will give you a falsely low uric acid level. Here's another huge practice update for you. Stop alkalinizing the urine. It's an old habit. We used to do it to make uric acid more soluble, but we now know it can actually make the whole situation worse. It prevents phosphorus from being excreted and increases the risk of calcium phosphate precipitation. You know, the very thing we're now most worried about. And while we're on the topic of fluids, yes, aggressive hydration is key. We all know that. But you have to be careful because there is a dangerous tipping point. Volume overload isn't benign. It's actually associated with more ICU admissions, a greater need for dialysis, and even higher mortality, especially in patients with AML. If TLS does develop, management turns into a rapid response drill. For that life-threatening hyperkalemia, you think membrane stabilization first with IV calcium, then you shift the potassium into the cells. For hyperphosphatemia, the goal is just to get it out with fluids and diuretics. And for any severe case that's not responding, hemodialysis is your definitive backstop. Okay, we have covered a ton of ground. So let's boil all of this down to the essential, practice-changing takeaways from this NEJM review that you can start using today. First, and most importantly, burn this into your brain, the shift in pathophysiology. With our great uric control, your number one concern for the kidneys should now be hyperphosphatemia. Second, your clinical suspicion for TLS just needs to get broader. These incredibly potent targeted therapies are creating new, high-risk situations in patient groups we used to consider pretty low risk. So keep your eyes open. And finally, your action plan. It's all about being proactive. You've got to carefully stratify risk, hydrate aggressively but smartly to avoid overload, and use your hypouricemic agents, especially Rasburicase, wisely and safely. So, I'll leave you with this one question to take back with you to your clinic or your ward. Based on this updated understanding, which of your patients, maybe someone about to start a new targeted agent, will you reevaluate for TLS risk tomorrow? A PowerPoint version of this presentation is available for download in the library section of drppt.in. Thank you so much for joining us for this medical update.